So I don't want you to be confused. I certainly understand that cephalosporins are part of the beta-lactam family of antibiotics, but because they are so commonly prescribed and they're all grouped together as a fairly large grouping of antibiotics, again known as cephalosporins, I really thought it might be sound for us to pull apart this subsection of beta lactam antibiotics to have a separate conversation about them. So I was trying to break down the cephalosporins just again because I've always felt that the cephalosporins were hard to get a handle on. Perhaps it's because they all start with C. I don't know, but I always struggled with them, and so I'm trying to give you some different breakout points in terms of not just the generations, the drugs that we most likely will be using in that generation, and sort of what they're known for. And so that's really the basis of this lecture. It's not to tell you every single thing about cephalosporins, but it's to tell you what I think is the most important and the most needed information for your clinical practice. Almost tuck this away for future use. And again, just know I'm trying to simplify what I've always felt was complicated, which is largely why infectious diseases was, although extremely interesting, also very complicated. So first generation, think cefazolin. And I say think cefazolin because it's really the only option you have out there. Second generation, really we're seeing activity against H flu, Haemophilus influenza. That would be cefuroximine. We're seeing activity against the bacteroids, which is cefoxitin and cefotetin. And I go into this in more detail. This is just a visual for you. The third generation, these are broad gram-negative activity, which would be cefotoximine, broad gram-negative with good Pseudomonas. Aeruginosa activity is ceftazidime. And then the fourth generation is your cefepime, and fifth generation, think ceftaroline. And again, as you get into the fourth and fifth generations, you're going to be talking about, if you're inpatient, getting an ID consult to utilize some of those medications. And we'll talk further about them and break them down. This is just a really basic slide for you to kind of grab a hold of some of the major points I'm trying to make. So when we think about the parenteral agents and their clinical use in terms of these cephalosporins, I broke down first and second generation together on one slide because when we talk about first generation availability, cefazolin is all we have. And cefazolin is used for treating most gram-positive cocci. And again, it's the only first generation agent that we have available in IV form. Second generation, when we compare it to the first generation, the second generation is less active against staphylococci. What we do use it for is pretty strong activity against H flu, and that would be cefuroximine. When we look at cefuroximine, we're also noticing that it's highly active against the beta-lactamase producing Moraxella catarrhalis. There's also in the second generation a cefamycin subgroup, which are active against the bacteroids. That would be cefoxitin and cefotetin. And when I say against the bacteroids, that means that they're active against most strains of E. coli, Pseudomonas mirabilis, and Klebsiella. And again, I recognize how challenging this is. Infectious diseases to me felt like I was learning medical terminology all over again because of all of the names of the bacteria that I had to know. So I am trying my darndest to break this down for you. I do understand it's a lot to handle at one time. Just try to make flashcards, break it down as best as you can. These are things you do need to know, especially for those of you who are going to be in acute care. The oral agents we'll get to in a minute. So what I want you to know about the clinical use third generation parenteral agents under the cephalosporin category would be that the use of the third generation cephalosporins is really to treat gram-negative bacilli such as E. coli, Proteus, Klebsiella, Enterobacter, Serratia, and Siderobacter. The third generation cephalosporins are less active against gram-positive organisms than first generation cephalosporins. So here's what we know. Cefotaximine, ceftriaxone have poor activity against Pseudomonas. Ceftriaxone, though, is known to treat the following: penicillin-resistant gonorrhea, Lyme disease, and meningitis from H. flu. Ceftazidime treats P. aeruginosa. Now, some of you might be saying, well, how do I know what my patients have? For those of you who are inpatient, you're going to know, you're going to get those microbiology results back, whether it be a wound culture, a urine culture, well, in this case, maybe CSF spinal fluid, or maybe a blood culture. And you're going to start seeing those basic gram-negative, gram-positive organisms coming back, and then the microbiology is going to show you, is it E. coli, is it Proteus, and then it's going to show you how resistant it is, and you've got to understand that. For those of you who are going to be inpatient, we will be spending time looking over microbiology reports and antibiograms in acute care pharm and in your courses. But that is how you have to start breaking down these drugs, because again, it's not one size fits all. It's a true science, and you have to understand. That's why we have so much antibiotic drug resistance, because people are just throwing antibiotics at people without understanding how to do this. In terms of the fourth generation options for parental cephalosporins, we have cefepime. It's our only fourth generation agent, so treat it nicely. Works well against really gram-negative bacteria. Has similar activity against pneumococci and MSSA, which would be methicillin-sensitive Staph aureus, as cefotaximine and ceftriaxone, like the third generation. Can be used to treat most pneumococci, Neisserii, H. flu, Enterobacter, Proteus, Citrobacter, P. aeruginosa, Serratia. Has a really broad base of what we can use it for, but it shouldn't be overused. A lot of times it requires ID consult. It does carry a risk of seizures, especially in renal failure patients, so you have to dose adjust accordingly. But again, I don't know what the percentage of that risk is, but textbook answer, I can honestly say I don't really remember seeing many patients ever with seizures as a result of its use, but again, it needs to be dose adjusted. So there's not too much that I'm going to spend time on with fifth generation drugs, because again, now you're really going into, you should be getting pretty much an ID consult at this point. So I would say ceftaroline works well against gram-positive bacteria. That should say Streptococcus pneumoniae. Kind of more known for its gram-positive activity. And cifidoracol is a medication. I don't think I've ever used it, to be honest with you. It is new. It is a fifth generation, and it's used for complicated UTIs only in the United States. From this point forward, we can start talking about some oral agents, and then we can just have a quick conversation about just just a little summary about a few items in terms of the pharmacology, and then we're done. I'm just going to add one slide in about oral agents, because really, a lot of the conversation was already about the cephalosporins, but very specific oral agents are listed here, and cephalexin, I feel like, tends to be the most commonly prescribed oral cephalosporin, which is Keflex. But obviously, the other medications here are certainly options for anyone to utilize. The oral third generation cephalosporins, I would just want to mention that they're active against Streptococci, H. influenzae, M. catarrhalis. They are more active than the other oral cephalosporins against the enteric gram-negative bacilli, including P. mirabilis, Klebsiella, E. coli. And as an aside, they have poor activity against P. aeruginosa, Acinetobacter, and Enterobacter. So, just something to consider. In terms of these antibiotics being recommended for use, generally things like upper and lower respiratory infections, UTIs, otitis media, tend to be some of the biggest uses. Okay. Okay, so let's have a conversation about the fluoroquinolones. And if you're not familiar with the fluoroquinolones, I'm talking about the floxacins, the levofloxacins, the ciprofloxacins, and their sister and brother agents. So the fluoroquinolones are really highly effective antibiotics. When we lay them out against other antibiotics, they're really still pretty effective. And they were highly effective when they first came out. So the pros of the fluoroquinolones, besides being highly effective, is that simply they're highly effective because they have high oral bioavailability. Again, it means you can take a pill and it works as well as an antibiotic that comes in an IV form, essentially. Large volume of distribution, broad spectrum antimicrobial activity, can be used for lots of different things, which we'll talk about. And the con is that because of their widespread use, now we see antibiotic resistance to them. They do have serious side effects, and there's lots of drug-to-drug interactions. So just to kind of break down what we're going to talk about in further detail. So the mechanism of action of these drugs, they are bactericidal. They inhibit bacterial DNA synthesis directly. What this means is that fluoroquinolones will generate DNA cleavage complexes that will result in the cessation of DNA replication, followed by DNA damage and subsequently cell death. So I have two slides on spectrum of activity for the fluoroquinolones, and the first one is sort of the overview and just some cheat sheets, if you will. And the second one, I'll get into more specific organisms, pathogens, and tell you which of the fluoroquinolones are best utilized. So, in general, fluoroquinolones have a potent activity against aerobic, enteric, gram-negative bacilli, and many of the respiratory pathogens. And you should all know that this is why when somebody has community-acquired pneumonia, you're seeing them go on Levaquin, right? Some fluoroquinolones are active against Pseudomonas, selected gram-positive organisms, anaerobes, and microbacteria. Now, again, we'll go through that in a little more detail. Cipro, just to break down a couple of these, Cipro has the greatest activity against aerobic gram-negative bacilli. Levo and moxifloxacin work well against the gram-positives, and moxifloxacin and delafloxacin seem to work the best against the anaerobes, but again, only to some degree. This isn't, they have some activity against the anaerobes, not perfect. So as mentioned, one of the selling points in utilizing these drugs is that there is a very high oral bioavailability with a large volume of distribution with the fluoroquinolones. All the drugs are absorbed in the upper GI tract. Again, there are IV and PO versions of almost all of the fluoroquinolones. And when we talk about the IV formulation, oxafloxacin and levofloxacin by far have the highest bioavailability in IV formulation, being greater than 95%. Delafloxacin is somewhere around 60%. Ciprofloxacin is about 70%. Moxifloxacin is somewhere in the mid-80 range. So your best IV formulation is going to be Levo and Oxa. In terms of how is it excreted, predominantly through the renal system. Okay, so this slide is going to be lengthy, and because there's lots that I want to tell you on this slide, I am going to say a lot versus writing down oodles and oodles of information. So let's take these one by one. Aerobic gram-negative bacilli and rods. So most fluoroquinolones are very active against aerobic enteric gram-negative bacilli. So what do I even mean by that? E. coli, Klebsiella, Proteus. These are called your enterobacteriaceae. And so I'm trying to break it down for you. But those gram-negative bacilli, E. coli, Klebsiella, Proteus, the fluoroquinolones do really well against those bacteria. Okay. Now, we could break that down further because moxifloxacin is not quite as good against Pseudomonas, aeruginosa. I'm not going to get into that right now, okay? So I could really break this down, and we're not going to do that. Respiratory pathogens. As mentioned in the prior slide, Levaquin, levofloxacin, and moxifloxacin are both active against most common respiratory pathogens. So that would be Streptococcus pneumoniae, Moraxella catarrhalis, Haemophilus influenza, H flu. Okay. Again, we're just going to keep that statement simple. Gram-positive organisms. So levo, moxi, delafloxacin are all active against certain gram-positive organisms, just certain, and that would be does pretty well against all Staphylococcus aureus, some streptococci, some strains of coag-negative staph. Just to make it a little more confusing, delafloxacin is also active against MRSA, MRSA. We don't use it very often for that, but just as an aside. So I'm not mentioning drugs like Cipro. Ciprofloxacin has very limited or no activity against gram-positive organisms. Okay, anaerobes. So of the available fluoroquinolones, it's only moxifloxacin that has some activity against anaerobic bacteria. Okay, you're not going to see it too much, but it's just out there. So perhaps maybe in aspiration pneumonia or lung abscess, you might see it utilized a little bit. So something that's not very common is things like tuberculosis, mycobacterial infections, anthrax. You can see fluoroquinolones being used against those types of anaerobes as well. In terms of mycobacteria, we are talking about Mycobacterium tuberculosis. And the fluoroquinolones are used as second-line agents in any sort of resistance type Mycobacterium TB, and when there's any intolerance to the first-line drugs, okay? So we see it in those areas. And then under other organisms, so things that we don't see as often like bacillus, anthrax, typhoid, there is activity against those very rare pathogens or organisms. So I went right to the side effects because I feel like in the last slide I said, oh, there's a lot of side effects and I better talk about them. And I don't want you to be afraid to use fluoroquinolones. We use them all the time. But I guess for me, the side effects became kind of front and center because we didn't really think there were many side effects. And then all of a sudden around, I don't know, I'm going to guess here, somewhere around like 2014, we got hit with all these side effects, and it was like, oh, now we kind of can't use this in everybody. So it's kind of, I don't want you to be scared to use them, but I do have to go through a couple of these with you. So the classic, GI upset, headache, dizziness, some transient changes in mood and sleep, which I've got to tell you, I saw once or twice in patients, and it was pretty profound. So it can be a true insomnia and a true sort of not psychosis, but like a pretty intense depression. Less common, but still, there is the C. diff concern. This is what got us, back like I was saying, like say 6-7 years ago, the tendinopathies and tendon rupture. So we did see some cases around the US of tendinopathies and tendon rupture. And so like the classic example was the day I had the 15-year-old patient who, by the way, no, I didn't see because I'm an acute care adult NP, but he needed to go on Levaquin, and oh, by the way, he was a pitcher for his high school team, and now what do we do? Because we were being kind of stuck in this box of, well, everybody that's going to use Levaquin is going to have a tendon rupture. That's not true, but it is something that in certain populations, like a growing teenage boy who plays baseball and is in the middle of their season, you might want to back off the fluoroquinolones. Aortic dissection, again, not something that we see often, but we see it especially in patients who are already at risk. So people who have like EDS, Ehlers-Danlos syndrome, or like some vascular diseases, uncontrolled hypertension, we might see it then. QT prolongation, again, can occur, doesn't necessarily happen too often. Avoid during pregnancy and lactation unless there's no other treatment available. And we want to avoid in myasthenia gravis patients as well. So those patients, we have to be careful. I would say it's a hard no. You do not want to use fluoroquinolones in those individuals because those patients with myasthenia gravis have neuromuscular blocking activity that, I'm sorry, let me rephrase that. The fluoroquinolones have neuromuscular blocking activity that can precipitate a myasthenia or a myasthenic crisis. I hope that makes sense. So again, you have to be careful about what that would mean. Would be potentially death, but also respiratory failure requiring mechanical ventilation, etc. If somebody went into a myasthenia related crisis because of fluoroquinolone use. So we do try to stay far away in those myasthenia patients. So just some additional side effects, and I'm saying this as additional because I think the ones I just mentioned are a little more discussed and more likely to be noted. Hepatotoxicity can certainly occur, but quite rare. Peripheral neuropathy and seizures also quite rare. I will say phototoxicity is real. You can get a bit of a sunburn, so you have to be careful with patients who are going to be out in the sun. And then hypersensitivity reaction with a maculopapular rash, which sadly so many antibiotics can do, but I shouldn't fail to mention it to you. So I would just add those in as well. So this is the rest of the beta-lactam antibiotics at this point. The cephalosporins have been eliminated from this conversation and put into a separate slide set, but again, they do go hand in hand. So just as a reminder from our cephalosporin lecture, the cephalosporins, the penicillins, the carbapenems, the monobactams, and beta-lactamase inhibitors all share a 4-membered beta-lactam ring, which makes them the beta-lactam antibiotics. Penicillins can be assigned to one of 3 groups. Classic penicillins, such as penicillin G, and they have good gram-positive coverage, some solid coverage against gram-negative cocci, and beta-lactamase producing anaerobe coverage. They are not good for gram-negative rods, and I would just star that. The anti-staphylococcal penicillins, like nafcillin, is your second category of penicillins, and the third would be the extended spectrum penicillins. And the extended spectrum penicillins have good activity against gram-negative rods. So that's where you got to, even within your penicillin categories, you have to understand there's differences. All beta-lactam antibiotics inhibit bacterial growth by interfering with the transpeptidation reaction of bacterial cell wall synthesis. That is, in essence, the mechanism of action. So we certainly know as healthcare providers already that there is resistance in terms of penicillin. And I felt like the best way to kind of give you that historical standpoint and context, as well as understanding the physiological aspects of why this is occurring, would be for you to listen to the 6-minute video that's linked at the bottom, the YouTube video, and certainly I think this will help clarify some of why that occurs. So in terms of pharmacokinetics, I tried to put down the items that would be of clinical use for you to remember, and that is keeping in mind that oral absorption is fairly erratic with the penicillins. It's for this reason that nafcillin is really only a antibiotic that's utilized in IV formation. Oral amoxicillin is the only penicillin that's not altered by food. So that's why it's so utilized with children. Most of the other oral options of penicillins need to be given an hour or two, preferably before or after meals. Another key point, IV penicillin G is preferred over IM penicillin G. Remember, we have both formulations available to us, and that's because of absorption properties. Also, who would prefer to have an IM injection of that size if they didn't have to? You know, there's local irritation and sort of integumentary related concerns. Penetration into the CNS is poor, generally speaking, with the penicillins. But we do know that patients have pneumococci or meningococci bacterial meningitis, and you can give fairly intense doses of penicillins that can be quite effective in treating those particular strains of bacterial meningitis. When it comes to excretion, the penicillins are excreted through the kidneys. It's about 90% tubular secretion, 10% glomerular filtration. With that said, let's just go through a couple things. Penicillin G has a half-life of about 30 minutes. If you give somebody who's in renal failure penicillin G, that half-life can go up to 10 to 12 hours compared to 30 minutes. So you do have to be extremely careful in your renally compromised patients. Ampicillin, which is a more extended release of penicillin, has a half-life of about an hour. So you can imagine if we're talking about renally compromised patients, that can go up to 10, 15 hours easily. So again, have to dose adjust in your renal disease patients. And then one caveat, and this is why you will see nafcillin used sometimes in those renal patients, is nafcillin is cleared mainly by biliary excretion. So nafcillin really is a standalone in terms of its clinical pharmacokinetics compared to some of the other penicillins. But again, you really do have to be careful with food. You have to be, in terms of absorption, overall with the penicillins, you have to be concerned about penetration into the CNS, and you have to be concerned about those kidneys, okay? Okay, so let's talk about the antibiotics that are really in this categorization of penicillin. We've got the initial penicillin G. We have penicillin V. Penicillin G comes to us in an IV form. Penicillin V comes to us in an oral form. And then we also know penicillin G comes in an IM form. To be honest with you, that's a 2.4 million unit IM Q weekly injection times 3 weeks, and that's for treatment of syphilis. The anti-staphylococcal penicillins, the cloxacillin, dicloxacillin, nafcillin, and oxacillin are the next group of medications we're talking about. Cloxacillin, dicloxacillin is your oral options there. Nafcillin, oxacillin are your IV options. And then we have the extended spectrum penicillins. That's the amoxicillin oral. Obviously, amoxicillin and clav, which is Augmentin, is oral. And then your Pip/Taz, which is Zosyn. I'm going to stop here and put the same slide up again and talk about how we actually use these medications in terms of bacterial usage. So just to keep this as clean as possible, I would just say that the penicillins, the penicillin G, dosing is 4 to 6 times a day. It's a drug of choice for infections caused by streptococci, meningococci, some of the enterococci, penicillin-susceptible pneumococci, staphylococci, that's non-beta-lactamase producing, etc. But again, the dosing of being 4 to 6 times a day is really challenging. Penicillin V, as I mentioned, is not really utilized that much. It would just be for some very basic minor infections. The penicillin G that we used to see in the IM version, just going back again, we're really only utilizing for syphilis. It used to be used for things like pneumococcal pneumonia and gonorrhea, no longer effective. The anti-staphylococcal penicillins that are listed, these are the semi-synthetic penicillins. So we're going to use these medications for infections that are caused by beta-lactamase producing staphylococci. Remember, the original drug in this category is the classic methicillin, but that's no longer used because of side effects. What I would like to have you sort of remember as a take-home message is the extended spectrum penicillins can penetrate gram negatives. So that's kind of the take-home message for this slide. So because we're talking about a lot of different formulations and medications in this group of penicillins, I'm just going to give you the highlights here. So generally speaking, fairly well tolerated, especially oral dosing. Oral dosing in high doses can cause GI upset. Oral dosing, both oral and IV, we can see some hypersensitivity reactions, but really a true sort of anaphylactic reaction is very rare. I know people want to talk about having penicillin allergies, but they're generally hypersensitivity. The other thing that we see so often is medications like amoxicillin can cause a rash, but that's due to Epstein-Barr, and it gets confused all the time as being a true penicillin reaction, and that's just not the case. We do have to be concerned about those renal failure patients and putting patients who are at risk for renal failure into renal failure with dosing penicillin wrong. Very high doses, there's a concern for seizure activity. In terms of just very basics according to each drug, nafcillin has a risk of having neutropenia or interstitial nephritis. Oxacillin can cause a hepatitis type reaction, and ampicillin a pseudomembranous colitis picture. Ampicillin and amoxicillin, again, causing that rash during some other viral etiologies like Epstein-Barr, being confused as really penicillin allergies. The other thing is Pip/Taz and Vanco being a combination drug that you see a lot in the hospital. Again, we have to be careful about people's kidneys. It can cause acute kidney injury, and a lot of times these are patients who are already at risk because of dehydration from whatever illness they have. So just keep that in mind as well. So let's talk about some of the other beta-lactam drugs that are available in the United States. Let's first start with the monobactam drugs, and we only have aztreonam as the monobactam available in the United States right now. It's a monocyclic beta-lactam ring, and because of that, it can only be used in gram-negative aerobic organisms. So Pseudomonas aeruginosa would be the classic. It has no activity against gram-positive organisms, which is completely unique to from the other penicillins. Of note, it can cause a transient rise in the LFTs, which resides once you stop using aztreonam. It can take a couple days, obviously. IV, Q8 hours, 1 to 2 grams per dose. Half-life is about 1 to 2 hours. It's much higher in renal patients, so it does have to be renally adjusted. And again, it's just one drug option right now in this class, which is aztreonam. So I'm going to keep this concept as kind of simple as possible and kind of know that I'm purposely saying less, thinking that the less I say, the better. So a drug like clavulanic acid, it's a beta-lactam drug, and it functions as a mechanical, like a mechanism-based beta-lactamase inhibitor, okay? So what that basically means is it's not effective by itself as an antibiotic, but it can overcome antibiotic resistance in bacteria that secrete beta-lactamase, which would otherwise inactivate most penicillins. So for example, I put down here, ampicillin and sulbactam together is useful in treating Staph aureus and H. flu. Okay, so again, these are not utilized in isolation, so to speak. Okay. So imipenem was the first carbapenem that was approved for use in the United States. We also now have meropenem, doripenem, and ertapenem. I tried to sort of break down the basics of each of these. Imipenem is good for use against gram-negative rods, gram-positive coverage, and anaerobes. Meropenem is similar to imipenem, and it's also useful against gram-negative aerobes. Okay, gram-negative aerobes. Doripenem is also like imipenem in its usefulness, and it's also useful against gram-negative aerobes, so very similar to meropenem. A lot of times you'll see a hospital have meropenem and or doripenem. I'm more familiar with meropenem. Ertapenem, which we don't see quite as often because it's the newest one. It doesn't work as well as the other 3 prior agents against P. aeruginosa or Acinetobacter species. And the thing with ertapenem is that it doesn't penetrate the tissues and the CNS that well. So in those particular cases, such as the CNS or soft tissue infection, you would want to go with imipenem, meropenem, or doripenem. All of these are cleared renally, so you have to dose adjust for renal patients. I listed here the daily kind of doses, or not daily doses, but the average dosing for the carbapenems. And just to make note that ertapenem is a once a day option, and that's because it has the longest half-life, which is 4 hours. So when we talk about another category within this conversation of other beta-lactam related drugs, we have to consider the glycopeptide antibiotics. And the classic one is vancomycin. If you see on the very bottom of this slide, I said telavancin, dalbavancin, and or itavancin are also listed. But let's be realistic. Telavancin is the one that you might see in the hospital setting. However, you're really going to see vancomycin first and foremost. And with the carbapenems as well as the glycopeptide antibiotics, aside from vancomycin, you're going to have to pretty much get an ID consult if you're going to want to use those drugs a lot of times. So let's really just focus on vancomycin. It's used for treatment against gram-positive bacteria. It's bactericidal against gram-positive bacteria as well. Of course, what I'm trying to say there, it's bactericidal. It's a slow bactericidal effect compared to some agents that we might talk about in a moment, but it's an oldie and a goodie. We use the oral version for treating colitis related to C. difficile because it's poorly absorbed in the GI tract. 95% excretion via glomerular filtration. So you know I'm going to say you need to renally dose it, and yes, that's the next sentence. Renally dose it and dose adjust related to the patient's creatinine clearance. We haven't talked a lot about what I mean when I say renally dose it, but that's what I mean. You're going to dose adjust to the creatinine clearance of the patient, looking at their labs. The dose on average for a normally functioning adult renal patient or non-renal patient is 1 gram IVQ12. Obviously, children, pediatrics of anytime I'm talking about drug dosing, obviously all bets are off when we talk about pediatrics. They must all be dose adjusted related to their weight. Oral Vanco for C. diff, the dose is 0.125 to 0.5 grams every 6 hours. Realistically, we're talking about 250 milligrams every 6 hours to somewhere between 250 to 500 milligrams every 6 hours. Used to treat MRSA, meningitis. Now, if you're treating meningitis, this is one of the agents that you use in combination with other antibiotics. So it's one of the agents we use as a combination of therapy. Obviously, C. diff, as mentioned. Adverse events, ototoxicity is rare, but we have to talk about it. We have to mention it. Nephrotoxicity, of course, is the thing we do get concerned about. And you've probably, as nurses, all heard about red man syndrome, and that's that flushing syndrome that if you just slow down the IV vancomycin rate by about an hour or two, it's going to go away, right? So it's an infusion-related flushing, and it's caused by a release of histamine. Some people are more susceptible to having that happen. There's really kind of no rhyme or reason. If it were to occur, we give antihistamine like uh, diphenhydramine or Benadryl, and that's kind of the end of the story most of the time, okay? All right, and last but not least in this little side set, I just put down the word other. Perhaps not the best way of describing these drugs. I think they're titled in some of the textbooks as other cell wall or membrane active agents. I'm not going to belabor that point too much. I kind of want you to know the clinical relevance of all of them, and not so much, that daptomycin is a cyclic lipopeptide. I don't really need you to know that. So let's just talk about these very basic, in a very basic fashion. Daptomycin is quite similar to Vanco. It does also, though, have activity against Vanco-resistant strains of Enterococci, VRE, as well as Staph aureus. So, ding, 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 that is a big win for Dapto. We use it against VRE. Phosphomycin is active against gram-negative and gram-positive organisms. It actually does come in an oral and IV form, but in the United States, you're only going to see oral phosphomycin approved at this point, really being used for an uncomplicated UTI. I don't see it very much at all, to be quite frank. Bacitracin, you're going to say, well, we've got an easy one here, bacitracin. Yeah, good old bacitracin, but remember, it is in this category of antibiotics, active against gram-positive organisms, highly nephrotoxic if it was given in a systemic form. So that's why we only have topical forms of bacitracin, rubbing it on your skin. Used for mixed bacterial topical infections, and I think we've probably all had a dose of bacitracin in our lifetime. Cyclosporin inhibits quite a few, actually, of the gram-negative and gram-positive organisms, but we've kind of limited its use these days to treating tuberculosis, and I really should be appropriate here in saying not just treating TB, treating Mycobacterium tuberculosis, to be precise. What you always have to remember with cyclosporin, and this is why it's not such a fan favorite anymore, is that high doses of the medication can cause central related changes. So things like pretty profound headaches, tremors, and acute psychosis. And that's all I have for this portion of antibiotics. I hope this helps. Hi, we're going to have a quick conversation about the pharmacology of the azoles. This would be the beginning of our conversation about medications to treat candida, mold, and yeast spores. Okay? So as mentioned, this is a conversation on basically our antifungal agents, the azoles. And amphotericin B was one of those initial antifungal agents that you probably don't see much at all. But just to give you some insight, 20 years ago when I was working bone marrow transplant ICU, amphotericin B, which we used to call amphoterrible, was our only drug option in this classification of medications. And so although it had terrible side effects and toxicities, it was our only option. Like I said, now I rarely see it at all. Instead, we see fluconazole, itraconazole, voriconazole, and the newer posaconazole and isovoconazole, and we'll talk about each of these and how they're utilized a bit further. So this is a slide to discuss the mechanism of action of the azoles, but really it's to tell you how these drugs work um, to kill the cell. So basically, the azole antifungals work primarily by inhibiting the cytochrome P450 dependent enzyme, which is lanosterol 14 alpha demethylase. Big fancy way of saying that this enzyme is really necessary for the conversion of lanesterol to ergosterol, which is the true vital component of the cellular membrane of fungi. And so when you disrupt the biosynthesis of ergosterol, you cause significant damage to the cell membrane and increase its permeability. When you increase the permeability, it results in cell lysis and death. So just some basic microbiologic activity with the azoles. The azoles demonstrate pretty similar activity against most Candida species. Voriconazole is the drug of choice against Aspergillus, as well as C. glabrata and C. cruzi. So voriconazole you will see in the hospitalized patient probably more than any of the other azoles. The newer posaconazole and isovuconazole has really increased the spectrum of use against the mucorales, and this is a newer concern, if you will, of a fungal species. And obviously, those newer drugs can still cover against yeast and molds, but they're being targeted for some of these newer concerns. Ketoconazole is a drug you probably have heard of as well. It's active against the endemic mycoses, dermatophytes, and candida species. So we see it more with skin, right? So let's take a minute and talk further about pharmacokinetics. So what we're going to talk about here is the pharmacokinetics of each of the drugs, excluding amphotericin B. And let's start with fluconazole. So it's available in oral and IV preparations. It's very hydrophilic, almost completely absorbed following oral administration with greater than 90% bioavailability. Absorption is not affected by food or gastric pH. Fluconazole distributes well into the cerebrospinal fluid. As with most of the azoles, it has a long half-life. In particular, fluconazole has almost a 24-hour half-life. And 80% of the drug is excreted in the urine, which makes it good for treating UTIs, but you have to adjust the dose with renal patients if that's the case. In terms of itraconazole, it is both a capsule and oral solution option. IV options are no longer available in the United States for itraconazole. Bioavailability is quite variable with itraconazole. It's about 55% bioavailability with the capsule, about 80% with solution. Of note, proton pump inhibitors will alter the absorption of the capsules. I should say the H2 blockers and antacids will as well, but because PPIs are more effective, greater absorption will be altered with PPI use. Oral solution should be given on an empty stomach. The half-life of itraconazole is 25 to 50 hours, and thus we can give daily dosing of itraconazole at 200 milligrams, again because of that long half-life. Metabolism occurs in the liver. Excretion occurs via the urine. And when the drug is excreted in the urine, there's no active drug. So this is not a good drug to treat with a UTI, or to use to treat a UTI. In terms of voriconazole, it is also good at penetrating the cerebrospinal fluid. It has extensive hepatic metabolism. So in liver patients, you can give a loading dose, and then you have to decrease that dose by 50% in terms of the dose that you use for maintenance. There is obviously a concern with hepatotoxicity with this drug. I'm going to skip that next line and just say that less than 2% is excreted in the urine as unchanged drug. So this also is not a good drug for treating UTIs. When you see the statement that there's nonlinear pharmacokinetics, I want you just to understand that a little bit better. So, what that means is that voriconazole, when you increase the dose of the drug by 50%, it can lead to a 150% increase in the serum concentration and thus a significant increase in serum half life. So, it's important to consider this because some voriconazole associated toxicities are directly associated with higher serum concentrations. So, higher doses of voriconazole have not been associated with improved clinical outcomes. So, more is not more, okay? And you have to be very careful with voriconazole that you're not giving too much of a dose that's more than what's needed. Again, because when you increase by 50% that dose, you're actually increasing by 150% what the patient actually receives in terms of the pharmacokinetics. Okay? So the pharmacokinetics of posaconazole, which by the way is noxafil, that's another name for it, noxafil. So initially we only had an oral preparation, and then I don't know, somewhere around like 2014-15, they came out with an IV option. And really the population that's utilizing this drug would be those who are at risk of really invasive aspergillus and candida infections. So, for those of you who are going to be doing outpatient medicine, you should not be thinking your patients are going to need posaconazole. But an example of utilizing the pill option would be used in patients who are neutropenic, who really are at risk of developing invasive fungal infections. So they might be giving a 200 to 300 milligram daily dose because they are at such high risk. So an oral dose should be given with food. The half-life is 27 hours. Also not useful in treating UTIs and is an inhibitor of CYP3/4A metabolism. Another name for isavuconazole is Cresemba with a C. And again, I'm just mentioning it because these are newer drugs available in both IV and oral options. I believe the oral option is a capsule. Don't think I'm going to ask you that, but I'm just trying to remember for myself. Half-life of this drug is an impressive 130 hours. That's not a typo. It has 98% bioavailability. It's unaltered by food intake. Drug clearance is highly dependent on the CYP3A4 metabolism, and therefore there are many drug interactions. And with these drugs, I will go through the drug interactions on separate slides because, quite frankly, the azoles do have quite a few drug interactions. So I'm just mentioning why there's drug interactions, and that's because of the CYP hepatic metabolism piece, but I'll go into more detail in upcoming slides. So then there's ketoconazole, probably the drug that is the most widely utilized outpatient drug aside from fluconazole. And why? Because there's several formulations, and that is as oral, cream, gel, a gel foam to be specific, and shampoo. Elimination is biphasic, so there's a half-life of 2 hours within the first 10 hours, and then it's every 8 hours thereafter. We're not going to get into detail why that happens, just it does. Most of the drug is excreted via the biliary system. Yep, biliary. Penetration to the cerebral spinal fluid is poor, so you do not want to use ketoconazole in a CSF infection. Just like some of the earlier drugs we were talking about, you want to advise patients to stay off of PPIs when using ketoconazole because of the gastric, the gastric pH alterations and then alterations to absorption. Significant inhibitor as well of CYP3/4A, hepatic metabolism. So the drug interactions do occur. And I see my typo here. CYP3, A4, not 4A. Sorry about that. So adverse effects, I would say with all of the azoles, you should be looking for GI symptoms as they are the most reported of the azole adverse effects, as well as hepatotoxicity. Because of the metabolism via CYP34A, you're going to see a lot of these drugs have the potential of causing hepatotoxicity. So I would always recommend with all of the azoles that you check liver enzymes, and or at least your patient's baseline liver function. Going through one by one, ketoconazole causes the most GI upset of all of the medications listed, as well as hepatitis, and it can cause adrenal insufficiency. Again, it's one of the older ones, so it has some more side effects related to the GI system. Fluconazole, long term, it can cause alopecia. Itraconazole can cause hypertension, hypokalemia, peripheral edema, and heart failure. Posaconazole, really, some minor GI upset, but adrenal insufficiency tends to be what we see if we're going to see anything. And vuconazole, GI upset, I mean nausea, vomiting, diarrhea, elevated liver function tests, and hepatotoxicity are listed, as well as, because it's IV, infusion reaction, like chills, shortness of breath, that type of infusion reaction, hypokalemia, and peripheral edema again. So I'm saving voriconazole all for itself because it takes the cake when it comes to adverse effects. We certainly know we need to use voriconazole in the hospital setting for certain patient populations, certain infections. However, especially, higher dose long term, remember what I said about that, increasing the dose of voriconazole by 50% means that you're increasing it 150%. So toxicities can happen very easily. And vision changes tend to be really noticeable. Things like abnormal vision, flashes of light, color changes, and this can occur within 30 minutes of oral or IV administration. It doesn't have to be long term. Neurologic toxicity, again, vision changes, like visual hallucinations almost. As well as things like confusion, agitation, myoclonic movements, auditory hallucinations. I mean, these are pretty profound. Skin toxicity includes things like photosensitivity reactions, so you have to be careful about that. Have been a few cases of even like a Stevens-Johnson type syndrome or toxic epidermal necrolysis, not as common, of course. Increased risk long term with developing skin cancer, specifically squamous cell. This is a really interesting, this fluoride excess, the periostitis, which really, I don't know if there's another drug that does this other than voriconazole that I can think of. And thank goodness, it appears to be due to really a fluoride excess. It typically will present as bone pain, elevated alkaline phosphatase, and characteristic findings along the periosteum, so the affected bones on plain radiographs and bone scans will show this excess fluoride. I did see this once, and I got involved because of the really elevated alk phos. So it does happen. It's rare, but it does happen. And it's people who really are on long-term voriconazole use, which again, in some of our patient populations, they're at high risk for pretty impressive fungal infections, so they don't have a choice. Cardiac toxicity also can happen, QT prolongation, torsades, cardiac arrest, sudden death. Again, not a typical side effect, but it can happen. And alopecia and nail changes can also happen. But these are generally patients who are taking the drug at least a month. And lastly, just some additional very important information. So we don't ever want to use the azoles in the first trimester of pregnancy. We don't know if they're safe. Monitor the serum drug levels. So this is especially true for anyone who, let's say, is interested in transplant. These are drugs that your patients are going to be on long term. And I used to have patients in the bone marrow transplant unit that were on these drugs for months at a time. Let me tell you, this is not just me saying this from experience, this is in the literature. These drugs, because of their long half-lives and their metabolism with the CYP3A4 system, you have to be extremely careful when you use them with other drugs. Because, for example, drugs that prolong the QT, such as amiodarone or haloperidol, you're going to really see a prolonged QT. In terms of the cytochrome P450-3A4 metabolism with some of these drugs, you have to be really careful that your patients don't get rhabdo, I should say rhabdomyolysis, with co-administration of certain statin drugs. Now, it's interesting because it's only certain statin drugs, but it's the ones we use the most. So, for example, it would be simvastatin for sure, lovastatin, and atorvastatin. But if you use pravastatin, fluvastatin, I'm forgetting the last one, rosuvastatin, sorry, I couldn't think of them all, those are okay. And so it really just depends because, and again, it depends on which ones are metabolized by CYP3A4, which is the simvastatin, lovastatin, atorvastatin. So again, these are all important things that you're not thinking about up until this point as the nurse administering these drugs, but now as the provider for sure. Voriconazole, sorry about the typo, and posaconazole will also increase sirolimus by tenfold. Now, sirolimus is not a drug that you're going to see that often, but if you are somebody who does transplant, these patients, this is exactly the population where you're going to see the long-term dosing of voriconazole, posaconazole, and sirolimus. Sirolimus is it's a drug that is essentially an immunosuppressive. Okay, so you can imagine this is exactly the population where you have to monitor the serum drug levels. You can't have sirolimus levels that are tenfold. You'll kill your patient. You must also dose reduce drugs like cyclosporin and tacrolimus, again, drugs that are so often utilized in that transplant population. So again, I know it's not for everybody, but a lot of us are going to be seeing these drugs utilized in IV formulations, long half-lives, a lot of GI interactions in terms of gastric acid, a lot of hepatic metabolism going on, and you have to be careful when looking at the cytochrome P450-3A4 interactions with other drugs, okay? Hope this helps. So another small slide set, and this time we're looking just at the tetracyclines. So without further ado, let's dive into this classification of antimicrobial agents. So the tetracyclines are not new. They were discovered in 1948, but just like we see with most antimicrobial agents, we're seeing newer and improved agents being developed all the time. Doxycycline and monocycline are most frequently prescribed today, and there are newer tetracycline agents called the glycocyclines, which tigacycline is one of the ones you may have heard of, and then newer agents subsequently came out in 2018, which I listed here. And these newer agents, with tigacycline included, have a much broader spectrum antibacterial activity than we've seen before. So the mechanism of action is essentially that the tetracycline can enter the bacterial wall in two ways. One, with passive diffusion, and secondly, with an energy-dependent active transport system. Once inside the cell, they bind reversibly to the 30S ribosomal subunit in a way that can essentially block the binding of amicosal tRNA to the acceptor site of the mRNA ribosome complex. This is a big fancy way of saying that all of this causes inhibition of protein synthesis and causes subsequent bacteriostatic effect. And just keeping in mind when we talk about bacteriostatic effect, we are saying that when something's bacteriostatic, it's capable of inhibiting the growth or reproduction of bacteria. That's different from bactericidal, right? Bactericidal is that it's capable of killing the bacteria outright. So I just want to make you aware of those differences. So when we talk about spectrum of activity with the tetracyclines, Again, we're talking about a broad spectrum bacteriostatic antibiotic that is used to treat infections caused by both several gram-negative and gram-positive bacteria. So it has a wide range. So in addition to the gram-negative and gram-positive bacteria, the tetracyclines can be used against many atypical pathogens. I only put a few down. There's probably 3 times as many as what I listed. But things like Rickettsia, Borrelia species, Burkholderia, Mycoplasma pneumoniae, Vibrio, Chlamydia. Um, uh, the list goes on. And some of these are, like I said, really truly atypical, so you won't see them that often. But certainly an infectious disease specialist needs to know how to use the tetracyclines for these particular circumstances. One note, though, especially for those of you who treat more outpatient, they don't work well against gonorrhea. Obviously, they don't work well against fungus or fungi and viruses, okay? And just an interesting point, and I think it goes back to more sort of just understanding pharmacology. Sometimes we think more is more. We would not want to put a tetracycline agent with a penicillin agent. Actually, putting the penicillin agent alone has better effect than putting them together. This is a combination then of a bacteriostatic and bactericidal agent. And basically what happens is putting these drugs together, you're basically cutting out the effects of the tetracycline. I'm just going to kind of leave it at that in terms of what happens. What we call that is a deleterious effect. And basically it's when you put a bacteriostatic and a bactericidal antibiotic together, the combination of the two is actually inferior to just the one, and in this case the one would be penicillin. The research behind that was done in because we used to treat pneumococcal meningitis kind of with the concept that more is more, and I would just want you to know that that's not true. So I'm trying to weed through some of the content in the book and give you some of the nitty-gritty specifics about what you actually need to know. And so I've just kind of whittled it down to the following. Doxy, IV, and PO options are available, which is what makes that drug particularly useful, especially in the hospital patient population. Bioavailability of Doxy oral is almost 95% with or without food, but oral tetracycline is decreased by 50% with food. So completely different outcomes with and without food for tetra. Routes of elimination. So tetracycline is mainly eliminated via the kidney by the use of glomerular filtration. Doxy via the intestinal tract for the most part. There are no dose adjustments needed for renal patients, which is really nice. And, these drugs are kind of a fan favorite of renal patients or nephrologists. For severe hepatic failure, though, you do need to consider a dose adjustment with doxy and tetracycline, but not minocycline. Sorry for my typo here. Children, especially in my day and age, were getting tetracycline, and it caused permanent tooth discoloration in children under the age of 8. And of course, we also gave medications, specifically antibiotics, for much longer and more judicious reasons back then. So there's a lot of us walking around with some permanent tooth discoloration thanks to tetracycline. Doxy does not do this, and so the pediatric societies have said that you can use doxycycline for less than 21-day duration of use in children. In terms of pregnant and breastfeeding women, so most tetracyclines are contraindicated in pregnancy, and we always are a little cautious with breastfeeding, but the literature says that although tetracyclines are found in high concentrations in human breast milk, concentrations are very low in breastfed infants. So this difference is probably due to the drug chelation with calcium in the breast milk and then the poor absorption of the chelated complex. I'm going to sort of leave that up to my FNP colleagues whether or not you want to use, specifically the tetracyclines with breastfeeding women. Why are they essentially contraindicated for pregnant women, and that is because of the risk of hepatotoxicity in the mother and adverse effects of fetal bone and teeth um, in utero exposure. Okay, so that is why. So I didn't write too much here because I think it's just easier for me to tell you some of these adverse events that can occur with the tetracyclines. And again, um, GI related symptoms tend to be the most discussed, and it's really related to both oral and IV agents. And this could be anything from abdominal discomfort, epigastric pain, the typical nausea, vomiting, anorexia, to really more of the alteration of the gut flora, some more chronic, long-standing diarrhea. And then we can even see some antibiotic-associated diarrhea caused by, C. diff, basically. So, you always have to worry about those types of things. Allergy and skin reactions, very uncommon, but, we do see it. And photosensitivity can occur, and that photosensitivity can cause a red rash or a blistering of the skin when somebody is on a tetracycline. So they have to be, counseled to avoid direct sunlight, wear protective clothing, sunscreen, etc. Teeth and bone, we've kind of talked about in the sense that the tetracyclines can cause that brown to yellow discoloration of the teeth in children under the age of 8. And that is really affecting the enamel of the tooth. The other thing that the tetracyclines have been sort of questioned about is that they can also deposit in the bone some like chelate formation with calcium, which, again, when children are forming, new bone, this is kind of a drug that you want to stay away from with children, okay, because of that calcium deposit that it can leave. Liver and renal we talked about. Again, hepatotoxicity is quite rare with the tetracyclines, but it could be fatal, so we have to dose adjust in those patients with pretty significant liver disease. And I would just say, in terms of renal, yes, certainly renal patients do fairly well considering the issues that they generally have with all antibiotics, but SIADH can occur in renal patients with tetracycline use. Tigecycline, starting back in like 2010, got a black box warning. I don't really see tigecycline at all anymore, to be honest with you, me personally, but it got a black box warning because of increased mortality with the use of patients who had HAP, hospital-acquired pneumonia. So again, I'm giving you all the drugs out there, but I personally don't see it much in use. In terms of drug interactions, I would just say that you have to be careful with the absorption of the tetracyclines being impaired, well, depending on which one, like we talked about with food, but also with things like minerals and acids like calcium, magnesium, and iron, dairy products, again, depending on which one you're utilizing, as we mentioned before. So I'm just mentioning the newer agents to you, and I'm certainly not going to expect you to be experts on these. I actually haven't used them. I'm putting down what they have been approved for, with Xerava being used for complicated intra-abdominal infections, sarecycline used to treat acne, and then the omadacycline used to treat CAP and acute skin infections. But I think we have to recognize is with antimicrobial stewardship and such concerns about misuse of all microbials, antibiotics, you're going to see less and less just usage of these just because they're available. And that's the job of infectious disease specialists around the country and pharmacists to really manage antimicrobial stewardship, especially in hospital settings where you would see these particular drugs probably most likely. And that's good. I'm glad I don't know them, because that means, we're using them in a limited fashion. The other thing is cost. I can't imagine how much some of these newer agents that we're going to talk about throughout pharmacology, but especially the antimicrobials, how much they cost. So again, we can't just use something because we want to. We have to be careful for multiple reasons. And really, we should be careful in terms of, does the patient even really need this level of tetracycline? So again, a lot of things that we'll teach you throughout the next year, and how to really use these medications, how to use the medications that we're going on over in pharmacology. Right now, we're just kind of giving you the bare bones so you get a handle on what class they're in and what their side effects are, etc. So in this very short slide set, I'm just going to talk about the macrolides. We have 3 antibiotics to talk about, and I'm going to try to keep it as simple as possible for you. So azithromycin and clarithromycin are macrolide antibiotics that are used in the treatment of several infections, including community-acquired respiratory infections, sexually transmitted infections, and mycobacterial infections. They're the derivatives of the older macrolide antibiotic erythromycin. And in terms of erythromycin and clarithromycin, they have a broader spectrum of activity than erythromycin has, having both gram-negative and gram-positive coverage. Azithromycin and clarithromycin have activity against the respiratory tract pathogens such as Haemophilus, Moraxella catarrhalis, Staphylococcus pneumoniae. They have coverage against some gram-positive and gram-negative bacteria, like the Mycobacterium avium complex, which we call MAC. Azithromycin, as an aside, is preferred for any community-acquired pneumonia because it has better coverage against H. flu than the other macrolides listed. And azithromycin is also used to treat STIs more commonly than clarithromycin. So without a doubt, acquired macrolide resistance is an increasing problem, especially with erythromycin, and that's because of overuse of the macrolides over probably the last 20 years. Clarithromycin and azithromycin have improved oral absorption, longer half-lives, and better tissue and cellular penetration than erythromycin. I mean, realistically speaking, erythromycin was the starting agent that we had in terms of the macrolides, and then, like everything else, the drugs that came after had better utilization, and because they're not as old, they also don't have quite as much resistance pattern to them. We give these medications in oral doses. Azithromycin has the longest half-life of 40 to 68 hours. So we generally will see a much shorter duration of azithromycin use. For example, you would see a 5-day course of azithromycin being used for the same treatment against whatever bacterium we're talking about, compared to clarithromycin or erythromycin, I'm sorry about my typo, being a 10-day course. In terms of pregnancy, azithromycin and erythromycin have more studies supporting its use than clarithromycin has, so I would recommend azithromycin if you had a pregnant patient, or erythromycin. Macrolides do have a lot of drug-to-drug interactions, especially azithromycin and clarithromycin. Many of which are mediated by inhibition of hepatic cytochrome CYP3A enzymes, or the P450 system. And so we do have to be careful of that. You can certainly look in textbooks and see a whole list of those interactions. In terms of side effects, GI intolerance, because of it being an oral agent, generally is what we see, but the things we also have to watch out for are hepatotoxicity. It's renal. It's not renally excreted; it's hepatically excreted. Biliary-wise excretion as well. QT prolongation. We can see anaphylaxis as well as Stevens-Johnson syndrome. Some eosinophilia and systemic symptoms, pseudomembranous colitis, and some hearing loss. And anyone who has myasthenia gravis could have an exacerbation of myasthenia gravis on the medication. So I didn't put every single one in there because the ones I listed are the ones that are most common. But again, it's a pretty long list. I would say, just as an aside, Empirically speaking, azithromycin seems to be better tolerated than clarithromycin from a GI standpoint. And again, because azithromycin has that long half-life, you have to be very concerned because if there is an adverse side effect, it can last for days upon days. Okay.